Hi, I'm Dr. John Emil Kenny, and we're in the home stretch. This is the final chapter, Chapter 8, entitled Dynamic Cardiovascular Monitoring.
So giving fluids in the intensive care unit is probably one of the most common interventions performed. And we give fluids to augment cardiac output, flow to the tissues. And we think about this whenever a patient in the ICU, which is exceptionally commonplace, suffers some sort of hemodynamic embarrassment. So they're not urinating, their lactate is trending up, their blood pressure is trending down. We think about augmenting cardiac output by giving preload. Interestingly enough, though, only about 50% of all critically ill patients have an adequate increase in cardiac output in response to a fluid bolus. So flip a coin, and you can determine which of those patients will have a hemodynamic bang for their fluid buck. In normal, healthy people on the street, preload responsiveness is really the rule. Essentially, everybody out there walking around with normal cardiac function, normal, healthy individuals, are preload responsive, and the thought is that that's to provide us some physiologic reserve for the flight or fight response when we're suddenly attacked by a saber-toothed tiger. We need to our evolutionary ancestors needed to be able to pick up the pace and get moving, but patients in the ICU are nothing like our evolutionary ancestors at all. So the question is, can we give fluids to a patient, and is that patient preload responsive? That is that patient going to respond to the fluids? But there's quite a bit of evidence now supporting the dangers of excessive fluid administration in the intensive care unit. The excessive fluid certainly injures the lungs, probably injures the kidneys, the gut. Anywhere you can get edema, you'll get organ dysfunction. So you can't just indiscriminately load patients with excessive amounts of volume. And also, I think really in the last 10 years or so, there's been quite a bit of mounting evidence showing that dynamic parameters, which is the focus of this entire chapter, are superior to static parameters when assessing whether or not a patient will be fluid responsive. And what are those things we'll get to in just a moment. So static parameters are hemodynamic variables that are just obtained at a given point in time. And they can be obtained invasively, like your classic central venous pressure, or PPAO is the abbreviation for pulmonary artery occlusion pressure. But you can also get static variables non-invasively. For example, if you put an echo probe on a patient and measure their left ventricular end diastolic area as a marker of preload or myocyte stretch just prior to the onset of contraction, that this is also a static variable because it's like a snapshot in time. There's no stress that's placed upon the system to sort of assay the cardiovascular response, which is really what the crux of dynamic parameters are. And the premise behind static parameters is the Frank-Starling relationship, which we've talked about quite a bit throughout these chapters. Chapter 2 is really where I initially introduce it, and that is if a filling pressure or cardiac volume is low, it's assumed that the patient is on the ascending portion of the Frank-Starling relationship, and therefore the patient would respond to a little more preload. And by the converse, if filling pressure or cardiac volume is high, then it's assumed that the patient's on the plateau of the Frank-Starling relationship, and therefore the patient will not respond to a bolus. So this is an animation demonstrating what volume responsiveness is. If you increase the right atrial pressure and you get an augmentation of your cardiac output, this defines volume responsiveness, and that's really going to be noted in this green area here. You can see that at right atrial pressures all the way up to maybe about here. Maybe I've drawn the cartoon a little bit far to the right, but certainly beyond this point you're on the flat portion of the Frank-Starling relationship, and any increase in your right atrial pressure via preload effect will not give you any increase in blood flow. Blood flow is on your y-axis here. The x-axis is right atrial pressure. And in a lot of these, I don't have values for right atrial pressure listed. I just want you to assume in all of them that the blood flow, the y-axis here, is at a right atrial pressure of 0. So pressure here is 0. Everything to the right is above atmospheric pressure, being 0, and everything below that pressure is subatmospheric pressure. So this is the volume responsive portion of the curve. And by contrast, this red portion would be the volume non-responsive portion, as I just mentioned, that giving preload and moving the venous return curve rightwards to increase the operating point. The operating point is the intersection of the venous return curve and the cardiac function curve. Moving that rightwards, certainly along here, you're not going to get any increase in your cardiac output from further preload. But because there are dynamic changes in cardiac function, it's very difficult to predict what a patient's curve looks like. So you have to imagine, if this is what you're using to predict fluid responsiveness in a given patient in the intensive care unit, you have to sort of have a mental idea of what their curve is and what the values of their right atrial pressure is for the slope of this curve, and that's essentially impossible to predict. Even with a good echocardiogram, you don't really know whether increasing somebody's right atrial pressure is going to augment their cardiac output. So for instance, in this patient here, this is a very different patient. Their venous return curve is shifted way to the left, so this patient may actually be functionally hypovolemic. But because their cardiac function is also poor, this patient is actually probably not terribly volume responsive. As I've indicated here, giving more preload to this patient is not going to increase their cardiac output at all. And interestingly, as I mentioned, this patient is actually hypovolemic. So there's a clear distinction between volume status, that is how hypo you or hypervolemic you are, and volume responsiveness, which is whether or not you're going to increase cardiac output from a volume challenge. Remember, volume status is determined by your venous return curve, its relative position on the x-axis there, where the x-intercept is defined by your mean systemic filling pressure. So that's volume status, whereas volume responsiveness is defined by the Frank-Starling or cardiac response curve. And that's just what I mentioned, that there's a distinction between volume status and volume responsiveness. So what are these dynamic parameters? Well, this requires that you're measuring a cardiovascular response to a given cardiovascular stress. And kind of a silly analogy, but I think that it works, and I think that it's something that you must bear in mind when considering dynamic parameters of cardiovascular function, is that if you were thinking of pharmacology, like a dose response curve for a given drug, you would never, want to compare responses to different doses. That is, if you wanted to evaluate a patient's response, you'd want to keep the dose essentially stable between all patients and then gauge their response from that. Because if you're interested in the response, if you're interested in changes in response, well, if your dose is simultaneously changing, you don't know if it's something inherent in the patient or if it's inherent to the fact that you're changing your dose. And the same applies to cardiovascular, the cardiovascular response to a given cardiovascular stress. And this relationship has been coined by, I think, Mike Pinsky may have been the author of this term, but this is functional hemodynamic monitoring. So the basics of functional hemodynamic monitoring is that there's some stress applied to your cardiovascular system. And in terms of pulse pressure variations, stroke volume variation, aortic flow output variation, and even changes in vena cava diameter. These are kind of classic things that we're assessing with functional hemodynamic monitoring. We're measuring that response, those responses that I just mentioned, in the context of a stress. And the stress is invariably a change in the intrathoracic pressure. So that change in the intrathoracic pressure hits your cardiovascular system, and that's the response. And what we look at is stroke volume variation And there's a whole bunch of different ways to measure stroke volume variation. For example, a surrogate of stroke volume variation is systolic pressure variation, pulse pressure variation, the change in the velocity time integral out of the aortic outflow tract. Aortic pulse contour analysis is another surrogate of stroke volume variation. So those are all sorts of, those are all basically different measures of LV stroke volume variation. And then that's sort of like an arterial side-based assay. And then you have the venous side assays, which is the change in the vena cava diameter. And I'm going to talk about each of these in turn through this lecture. And as I mentioned, it's sort of this pharmacology relationship. You want the stress or the dose to be standardized. And if you start having changes in your stress or your dose, then changes in the response, you don't know if it's something that's inherent to the system itself or if it's inherent to the stress. And that's what I just said. So this is an example of functional hemodynamic monitoring. So what we do is we're going to stress this system, and the response is we're trying to assay whether or not your venous return curve is intersecting the cardiac function curve on its ascending portion. We want to know that it's on the ascending portion because then we'll know whether or not the patient will respond to a fluid challenge. So as we mentioned in Chapter 2, the x-intercept of the cardiac response curve is actually intrathoracic pressure. Again, this is right atrial pressure on the x-axis and blood flow on the y-axis, and this line here marks atmospheric pressure, subatmospheric, supraatmospheric. And again, if you were to arrest the circulation and uncouple venous return, and you measured the pressure in the heart at zero blood flow, you would essentially measure the pleural pressure or the intrathoracic pressure. And bear in mind, throughout all of my lectures, for simplicity, you can use pleural pressure and intrathoracic pressure interchangeably. Okay, so the stress is you give a mechanical breath. The patient is completely passive or and potentially paralyzed, and therefore the change in intrathoracic pressure is a function only of tidal volume and chest wall compliance. The intrathoracic pressure rises, okay? Your cardiac output drops as a function of the increase in intrathoracic pressure on the right side of your heart, and you measure that a few beats later as a decrease in your left ventricular stroke volume or pulse pressure. And you say, well, that pulse pressure variation is therefore a marker of the patient's right heart being on the ascending portion of their Frank-Starling relationship, and therefore this patient will respond to a fluid bolus. By contrast, if you took another patient who's now on a flat portion of their Frank-Starling relationship and you apply the same stress, so you can see that blue arrow is moving to the right to the same degree, but now you can see there is essentially no change in the forward flow from the right heart. With this stress, the same stress, this patient will not have the same amount of left ventricular output variation, stroke volume variation, pulse pressure variation, and this patient will be deemed to be volume non-responsive. Okay, so you can see here that this idea of preload is not necessarily equivalent to preload responsiveness. These patients have different preloads. Certainly the initial patient had a lower preload than the second patient, but the fact that in response to a cardiovascular stress, there was no change in the forward flow, this patient is not preload responsive. This patient is volume unresponsive. So the responses to the cardiorespiratory stressors are commonly evaluated, as I've mentioned, both on the venous side, for example, changes in the IVC calendar caliber, which I'll talk about at the end of the second half of this lecture, and on the arterial side of the heart, that stroke volume variation and its many surrogates, as I mentioned. A couple of points. These tests of cardiac function were derived under italicized very specific conditions. So these are highly standardized stressors or highly standardized doses that are being applied to the cardiovascular system. And once you start deviating from those conditions, the responses that the cardiovascular system may have may not be reflecting volume responsiveness, but rather just changes in the stressors applied. And that the tests will then carry varying sensitivities and specificities. Recall, like any diagnostic test, the test is meant to alter your pretest probability. So if your pretest probability for volume responsiveness is very low, so a patient who comes in with an EF of 20%, who's anasarchic with ascites, is cool and clamped down, and you look at their pulse pressure variation and there's ample pulse pressure variation, well, it's probably the patient is not fluid responsive. It's probably a false positive, and we will talk about actually why you can see that. So none of these tests, like any of the tests that I've talked about throughout these lectures, is the quote-unquote silver bullet. So this is one graphical illustration that I want to present to you before we move on to the second part of this chapter. This is just for illustration's sake of why standardization is so important. That is, if a patient's physiology or clinical state differs significantly from the patients in whom these test characteristics were derived, then the sensitivity and specificity of a given pulse pressure variation or stroke volume variation threshold will change, and that is the percentages of false negatives and false positives will change. So first of all, consider that stroke volume variation, pulse pressure variation require an increase in intrathoracic pressure to stress the preload reserve of the heart. In these patients, the change in intrathoracic pressure must occur in a patient fully adapted with the ventilator, so there's no spontaneous inspiratory or expiratory efforts, and these patients are on at least 8 cc's per kilogram tidal volume with normal chest wall characteristics. So why is this so important? Well, let's take a step back. Let's take a step back to Chapter 1 and reconsider the Campbell diagram. So the Campbell diagram, again, is a way of depicting this airway pressure is not accurate right now. It will be in a moment. That's the modified Campbell diagram. But the Campbell diagram measures intrathoracic or pleural pressure on the x-axis, ignore this for right now, x-axis, with thoracic volume on the y-axis, and it graphs these, allows you to visually appreciate these in terms of both the elastic characteristics of the lung, the chest wall, as well as the dynamic characteristics of both of these things. So under no airflow at a given thoracic volume, the distance between these two curves, again, this is the chest wall elastance curve when the chest wall is fully passive. The chest wall is at rest. There's no inspiratory or expiratory muscle efforts at all, so I call this chest wall diastole. This is therefore FRC, the volume where the elastance curve of the lungs and the chest wall intersect, and you can go back to Chapter 1 to review this. But at areas of no airflow, the lateral distance between these two curves is the pressure that must be generated by the inspiratory muscles to maintain a particular thoracic volume. Now, because most of our patients are on a ventilator, you can also say, well, if I wanted to get to this volume here, that the pressure between the lung elastance curve and the chest wall elastance curves, this is the pressure that the ventilator must apply at the proximal trachea. This is where the airway pressure comes in to maintain that volume. And again, these are volumes at zero airflow, so this is like a plateau pressure. So if you were to serially graph these, you'd actually get a compliance curve for the respiratory system. So this is this line here. So each of these airway pressures, this is now airway pressure, is the pressure that must be applied at the proximal trachea to maintain the lungs and chest wall at each of these specific volumes. Okay, so that's the airway pressure. Now there's a lot of confusion. The airway pressure is not the same as the pleural pressure. This is It seems to be an immense amount of confusion amongst a lot of people in the intensive care unit. The pressure that you are measuring on the ventilator from the proximal trachea, the peak pressure, the plateau pressure, those are airway pressures. That is not pleural pressure. When a patient is fully passive with the ventilator, not generating any inspiratory or expiratory efforts, the patient's pleural pressure follows the chest wall elastance curve. So the pleural pressure follows this curve. And the reason that is you can sort of think of it as the ventilator is pushing air into the proximal trachea. It then increases the transpulmonary pressure, the lungs inflate, the lung volume increases, and then the lungs push out against the chest wall. Okay? And as the lungs push out against the chest wall, the pressure between the lungs and the chest wall generates your pleural pressure. And you can see that that would be entirely, in the passive patient, a function of tidal volume and the chest wall compliance. So at this tidal volume, this blue tidal volume, the chest wall compliance curve is here, so this would define the pleural pressure. Okay? So what happens when somebody has a low chest wall compliance? Well, the chest wall compliance curve shifts down and to the right. Now there's a greater pressure difference between the lung and chest wall curves. So a greater pressure must be applied by the ventilator at each volume to affect each given volume. So now if you were to graph this out, well, your respiratory system compliance curve is shifted down and to the right. So this is impaired respiratory system compliance. So your airway pressures will go up for a given volume, but also because of the poor chest wall compliance at a given volume, your pleural pressure will go up as the lungs push out against this stiff chest wall. So again, at this volume here, or this volume, or this volume, or this volume, the plateau pressure that you measure on the ventilator is here, but the pleural pressure follows the chest wall elastance curve, and that's the pleural pressure you can see is much higher in this patient than the patient on the previous slide. Okay, so when the thoracic compliance is due to when the drop in the thoracic respiratory system compliance is due to a drop in the chest wall compliance, out of proportion to the lung, much more of the airway pressure is transmitted to the pleural space. Okay, so why am I taking on this long roundabout explanation of airway and chest wall compliance as it pertains to functional hemodynamic monitoring? Well, let's take a look at it on this idea that I've proposed in essentially all of these lectures of a graphical representation of heart-lung physiology that is marrying the Campbell diagram on the XZ axis. So X is still pressure, intrathoracic pressure, or intravascular pressure. And here the z-axis is thoracic volume. Okay, so this is the same Campbell diagram. It's just laying down into the page. So this is the elastance curve of the lung going into the page. This is the elastance curve of the chest wall going into the page, and this is a given volume that you're trying to reach. Okay, so if you were administering a mechanical breath on a volume-limited form of ventilation, which is the type of ventilatory mode that was used in all of these studies, the intrathoracic pressure, which is the stress on the cardiovascular system that we're measuring, will rise along the chest wall compliance curve. So if you were to give this patient a breath and they were fully adapted with the ventilator, that is not generating any inspiratory efforts, their pleural pressure would follow the chest wall elastance curve. It would go from the pleural pressure here. So again, this is pressure. Sorry, it's not well indicated here, but this is pressure on the x-axis. This is your intrathoracic pressure, and you can see it's slightly subatmospheric at functional residual capacity. Okay, so it's slightly below. This is your atmospheric pressure. And this breath, say, takes them from slightly subatmospheric to essentially atmospheric pressure. Okay? Now imagine another patient with very poor chest wall compliance. So the chest wall compliance is shifted down and to the right like we saw on the previous slide. Well, the same breath will take them to a much higher pleural pressure. You can see, so their pleural pressure or intrathoracic pressure is way up here for the same tidal volume breath. Okay? So now let's superimpose this on the Guyton analysis. So now the x-axis becomes your intrathoracic pressure or your intravascular pressure. So this is intrathoracic pressure at the x-intercept when there's no blood flow, and this is your central venous pressure, which is determined by the intersection of the cardiac function curve and the venous return curve. So this patient, I think you would agree, is volume non-responsive. They're clearly on the plateau of their cardiac function curve, so giving them more preload, shifting the venous return curve rightward, is not going to augment their cardiac blood flow at all. So you're going to give this patient, okay, a mechanical breath. And this first patient, patient A, has normal chest wall characteristics. So their intrathoracic pressure will shift along the chest wall compliance curve like this, okay? There's been no change in their cardiac output, so this patient will be deemed volume non-responsive, okay? What if we gave the exact same mechanical breath to a patient who's volume non-responsive but who has a very poor chest wall compliance? A patient who's got ascites or massive obesity or some sort of age-related bony abnormality that's decreased their chest wall compliance. Well, now their intrathoracic pressure is going to increase to a much greater extent. And look what's happened. You've actually now dropped their cardiac function curve, you've dropped their cardiac output as a function of this increased airway pressure. There'll be a drop in forward flow, which will be measured as a few beats later as pulse pressure or systolic pressure variation. This patient was volume non-responsive, but because this stress on the cardiovascular system has not been standardized, this patient is having their physiology assessed under different conditions than the initial patients were in those initial studies of pulse pressure variation. The greater the increase in intrathoracic pressure, which is the cardiovascular stress, will give you a different cardiovascular response and essentially a false positive result. So this will degrade the specificity of pulse pressure variation. So you can see higher intrathoracic pressure, even though it's going to the same volume. You're giving this patient, say, 8 cc's per kilogram tidal volume breath. Because of their poor chest wall compliance, the intrathoracic pressure is increasing to a much greater degree. You're stressing the preload reserve of the right heart to a much greater extent, and you're actually dropping its cardiac output. So this was an example. This is why I went through that long discussion of the Campbell diagram to help illustrate how these pulse pressure and stroke volume variation variables were derived under extremely specific conditions. They're context specific, and once you lose that context, you lose the sensitivity and specificity of these parameters. So that's it for the introduction, some basic physiologic considerations of functional hemodynamic monitoring. Over these next sections, I'm going to turn to the physiology of pulse pressure variation and stroke volume variation in both the passive patient, the spontaneously breathing patient, and then the patient who is on a ventilator and triggering breaths. And I'm going to go through a lot of the physiology of that. And then beyond that, I'm going to talk about changes in IVC caliber, and then a little bit later, in one of the later sections, the passive leg raise test. Thanks.